Hi, everyone. Thank you for joining us. My name is Donna, and I'm with GENESIS Fertility. Conducting today's webinar is Dr. Katherine Ross of GENESIS. I'm going to ask everyone to please hold all questions until the end of the presentation. And without further delay, I'll turn the controls over to Dr. Ross.
Thank you, Donna. Thanks everyone for joining this morning. So the goal of today's webinar is to talk about egg freezing and to go over the basics of it, answer any questions that you might have, and sort of give you my thoughts on that. Um, so Unfortunately, there's often a misconception that women are fertile well into their late 40s and 50s. And that's because of all the media that you see out there of older women having babies. But to be honest, a lot of these women may have frozen their eggs when they were younger, or perhaps have used donated eggs from a younger woman, but may not necessarily be forthcoming about all that information, which is understandable. Um, the issue is that women are born with a finite number of eggs, which we also call oocytes. In fact, we actually have the most number of eggs we ever will while we're still gestating in our mom's bellies at about 5 months. And from there on, the number of eggs starts declining. And so by the time we hit puberty, there's probably hundreds of thousands of eggs left. And once we enter our mid to late 30s, we do see that the number even continues to decline at a faster rate. Um, this slide sort of depicts the same thing, just in a visual version. And you can see that the highest number of eggs, which they call germ cells in this slide here, are actually present before we're even born. And then the number continues to decline until a woman reaches menopause, and that is when all of the eggs have been depleted and one no longer ovulates. The average age for menopause for most women is around 51, although some women have an earlier age of menopause and other women have a later age of menopause. Unfortunately, this is in contrast to men who regenerate their sperm every 3 months. So women are definitely at a disadvantage in this regard. So the goal of egg or oocyte freezing is to try and preserve the eggs when they are younger and healthier. So this slide sort of depicts two things. One, the dark line, um, the solid line is the number of egg follicles that a woman has. And as you can see, it declines as one gets older with the optimal fertility when the eggs are at their best, is when women are in their 20s and early 30s. And unfortunately, the dashed line here is the proportion of eggs that start becoming abnormal. So as we get older, the number of eggs goes down and also the quality goes down. And when I say quality, that means an egg that's capable of producing a healthy child. So to conceive a healthy child, one needs to make an egg that has 23 chromosomes, and that fertilizes with a sperm that has 23 chromosomes. And most people have about 46 chromosomes. So the goal of what we call planned oocyte cryopreservation is to harvest and freeze the eggs while they are still abundant and also healthy. So next I'm going to talk a little bit about what an actual cycle entails and what a woman does during the cycle to try and make those eggs grow. So what happens for most women in a normal menstrual cycle is that at the start of their cycle, this is what the ovary looks like on the left. So the little black circles, those are called egg follicles. And within each of these little black circles, ideally, is one egg. So In a normal cycle, what happens is that the body recruits a few eggs at the beginning, and then one ultimately becomes the winner. We call this the dominant follicle. And this is the egg that is released in that month. And so if a woman has a nice number of resting egg follicles like this ovary on the left, the hope is we can get a nice number of eggs to grow. Um, so what we do with egg freezing is rather than just that one egg follicle becoming the winner that month, the goal is to stimulate the ovaries to make multiple eggs grow. And then these eggs can be frozen for future use and can be frozen for many, many years until a woman is ready to use them. In order to get the ovaries to this state where there's multiple growing egg follicles, we teach you how to do self-injections. So there are sub-Q injections that a woman gives to herself, generally in the evenings. Um, and these injections are designed to make multiple eggs grow. So rather than just the one egg becoming the winner, the hope is to get 10, 15, or even 20 eggs to grow. In order to do this, one needs to do injections for on average around 10 or 11 nights. And during that time, we're watching you closely to make sure the eggs are growing well. So at the beginning of the cycle, normally we'll have you come in on day 2 of your period. If everything looks good, you'll start the injections that night. And we'll normally bring you back in around day 4 or 5 of your cycle to check and see how the eggs are growing. And then during the second week of the cycle, we may start to need to see you for a few days in a row to check and see if the eggs look ready for the egg retrieval process. Um, at the final stage, we ask you to do one final injection. We call it a trigger shot, and that matures the eggs so that they're ready for retrieval. This is a picture that demonstrates what happens in the egg retrieval. So it's a procedure that we do under anesthesia. So you do have some sedation and you don't feel it. In the days leading up to the egg retrieval, you may start to feel a little bloated, have a little discomfort, and that may last also for a few days after the retrieval. But the goal for the actual procedure is for you to be sleeping and to be comfortable. There's no incisions needed on the belly. What we do is we place the probe into the vagina, and attached to the ultrasound probe is a little needle, and that just goes into each of the egg follicles and takes the fluid out of the follicles. And there's a lab specialist called an embryologist who isolates each of the eggs under the microscope and freezes them. On the day of the egg retrieval, we ask you to arrive about an hour prior to the procedure to meet the team. Like I said, the procedure itself only takes about 15 minutes, but we do have you recover for about an hour to make sure you're feeling okay before you go home. We want to make sure you're not too uncomfortable, you're not nauseous from the anesthesia, and things like that. After the procedure, we let you know how many eggs we were able to retrieve. Any of the eggs that are mature will freeze that same day. If there are some eggs that only partially mature, we will keep them overnight in the lab and see if they mature overnight, and then we're able to freeze them the next day. And as I mentioned, these eggs can be frozen for years. After the retrieval, we do expect you to have a little bit of cramping and some spotting for a few days. Most women will only need Tylenol or Advil or Motrin for pain. It's unusual for anyone to need anything stronger than that. Depending on one's job, we do think you can most often return to work the next day, although if you have a very high impact type of job, we might suggest you take a few days off or take it easy. The bloating that you'd experience should resolve within 3 to 7 days after the retrieval and be fully gone by the time your next period comes, which is typically about 7 to 14 days after the retrieval. So some things to consider when going into the cycle. There is something called ovarian hyperstimulation syndrome. This is when the ovaries get swollen, which is normal, but women can also have more um, side effects like feeling nauseous or throwing up or very bloated. With the medicines that we have available to us today, this rarely occurs in the moderate to severe form. We still have patients that have a mild degree of hyperstimulation where they're feeling bloated, a little uncomfortable, may need to take a few days off from work. Um, but it's rare to have any more serious version of hyperstimulation. The other thing we worry about is that sometimes we have to cancel the cycle if there's not enough egg follicles growing. Of course, we talk to you during the cycle if this is something that needs to happen. Another thing to consider is that some women may freeze their eggs and not need to use them. So, if you freeze your eggs, if one freezes their eggs early enough or young enough, and within a few years have decided to pursue actively being a parent, they may not have no trouble conceiving and may not need to use the eggs that they've had frozen. The fourth thing to consider is that we don't have any long-term data yet on the children born from egg freezing. We do have a lot of data on babies born using in vitro fertilization, and overall that's very reassuring. So we assume that hopefully the babies born from egg freezing will similarly not have many issues like those born from IVF. We do know babies born from IVF do have a slightly higher risk of birth defects from those born naturally. So in the natural population, the risk for birth defects is about 2 to 3%. With IVF, that number is increased to about 2.5 to 3.5%. So that is one thing we take into consideration when talking to patients about IVF or egg freezing. And the fifth important thing is while we like to call this an insurance policy, no insurance policy is 100%. So depending on one's age at the time of freezing and how many eggs are frozen, um, can give us an idea of what one's success rate might be later. But unfortunately, there's no guarantees. So many patients come and ask us, what if I want to check my eggs? What are you going to do? How do you do that? So this can be done with us or even your regular OBGYN can do some of the testing and potentially refer you to a fertility specialist if needed. So there's three main things that we look at when we're assessing a woman's what we call egg reserve or egg count. So we can see sort of on that graph where your egg follicle number may fall. So one thing that we do is an ultrasound. And like that picture I showed earlier, we look at the ovary and we see how many of those resting egg follicles there are. This is called the antral follicle count. So if we see about 10 resting antral follicles on each side, left and right ovary, the hope is maybe we can get 20 or so eggs to grow with the cycle. In addition, there's two lab tests that we do to check the egg reserve. One is called FSH. This stands for follicle stimulating hormone. This is a hormone made by the brain to tell the ovaries to make a follicle each month. This really should be drawn on day 2, 3, or 4 of one's period to be accurate. Unfortunately, this one is not accurate though if someone's on birth control pills. Um, so for our patients who are on birth control pills, we generally recommend drawing a different hormone level called an anti-Müllerian hormone level, or AMH for short. And we draw this for all patients as well as those not on birth control. This is a hormone that's produced by the resting egg follicles. It can be drawn at any time of the cycle and is not impacted very much by birth control pills or IUD or other forms of birth control. So this is just a schematic sort of showing what those follicle and what those hormones mean and where they come from. So in younger women, the AMH level is often high. We like to see it above 1 because this is the hormone made by the resting eggs. And typically we see the FSH level coming from the pituitary gland of the brain. Typically that one is lower. As women get older and there's less eggs available, the AMH level will start to go down and the FSH level will start to go up as we see the brain working a little bit harder to try and tell the ovary to make an egg each month. So a lot of patients ask, should I be worried? When should I come see you? Or when should I do a cycle? And it's hard to pinpoint, and the answer is not the same for every woman. So we're all born a little bit differently, and we all have different histories. So it's hard to, you can't give a same answer to everyone. Some of the things we do know put women at a at a higher risk for a lower egg count are a few things. One is smoking cigarettes, so that definitely hastens the loss of the eggs. The second is a family history of early menopause. So I often encourage patients to ask their mom how old she was when she went through menopause. Typically, as I mentioned, the average age of menopause is around 51. For women that experience menopause in their early 40s, that's a little bit of a red flag. And so typically, if your mom did have an early age of menopause, that would be a reason to consider coming in for a consult. There's a condition known as endometriosis as well. This is a condition where that's generally the hallmark is very painful periods. And we think the primary reason why women have endometriosis is that instead of when they get a period, instead of all of the menstrual blood coming out, some of it goes backwards through the fallopian tubes and causes some inflammation and scarring inside the pelvis. And unfortunately, this can also affect the egg quality, excuse me. Um, the fourth thing that we know can affect the egg count is any treatment for cancers, such as chemotherapy or radiation. And so for those women, we counsel them about freezing their eggs before they have to undergo any sort of cancer treatment. So the best thing is, if you're at all worried, is to at least come for a consult and we can do that testing that I mentioned and decide if this is the right option for you now or later, depending on how the testing comes back. So the other important thing to consider is the cost involved. So most insurances don't cover the cost for planned oocyte cryopreservation, although there are a few of the larger companies that have started covering it, and we can look into that for you if you're unsure. But in general, depending on the center that you go to, there'll be a cycle fee, like a package fee, which includes all of your blood work, your ultrasounds, the retrieval, the freezing of the eggs, and that can vary anywhere from $6,000 to $10,000. There are companies that offer financing so that it's not something you have to pay all up front. The medications are separate from the cost of the cycle. So these can vary depending anywhere from $3,000 to $5,000. So it's going to generally the medications are dosed based on one's age, one's egg count, and one's BMI. So So that sort of is why there's a range there, because everyone's dose is a little bit different. Um, there may also be a surgery center fee for the egg retrieval and an anesthesia fee. It depends, depending on where you are, if that's included in the package that you've been quoted. And then another thing to consider is that there is going to be an annual fee for keeping eggs frozen. And so, as I mentioned before, one of the pitfalls is that some women may not need to use their eggs, but one does incur the storage fees over time. And then the last thing to consider is if one does need to use one's eggs, what happens to those eggs when you are ready to use them? So, um, this process typically involves either coming back to the center where the eggs were frozen, or actually eggs can be shipped to another fertility center if you've moved since they were frozen. The eggs are normally thawed and then injected with one sperm into each egg. Um, we normally expect about 90% of the eggs to survive the thawing process. And the day after the egg and the sperm are placed together, we look to check for fertilization, which is the second picture here, um, where we see a nucleus from the egg and a nucleus from the sperm, and that tells us the embryo is fertilized normally. On average, we expect about 60 to 70% of the eggs to fertilize normally. And then the embryos are grown in the lab until ideally day 5, which is this last picture here, the embryo has reached what we call the blastocyst stage. Of the embryos that fertilize normally, we typically expect about 50% of them to make it to this blastocyst stage. And so that's why when you start with a batch of a certain number of eggs, the number of eggs that actually will make it to a developed embryo is lower. And then typically the embryo or embryos can be transferred back into the uterus. This is not a procedure that needs anesthesia. And in advance of this, we've gotten the endometrium or the lining of the uterus ready for transfer to maximize the chances for implantation. So as I mentioned earlier, it's very important, age is very important in terms of one's success rate. So typically we encourage women to consider egg freezing before age 40, ideally before age 38, because the numbers are fairly reassuring up until that time. For women, when they freeze their eggs at 40 or 42, it's going to take quite a lot of eggs to potentially result in a live birth. So for most women that do a cycle, if they're young and their egg count is good, we typically expect to get about 10 or 20 eggs frozen from one cycle. Generally, the women who fall in this last row here with 40 or more eggs frozen, those are women that have done multiple egg freezing cycles. It's rather unusual to get 40 eggs frozen from one egg freezing cycle. So that's the main things that I had to discuss today, and I did want to leave a good amount of time open for questions. So, Donna, if you want to open up the floor to questions, I'm happy to try and answer some. I guess one thing I'll just add on a personal note is people have always asked, when would you freeze your eggs? And for me, I always felt 35 was my age cutoff for freezing my eggs. If I had not um, met anyone by age 35, that's when I would have done it. So that is typically what I counsel patients is if you can make it happen around age 35, that's when you're really gonna um, maximize maximize your outcomes. If you wait until 40, 41, that's not the best time to consider doing it. So normally I suggest getting the AMH checked annually. Um, we typically expect the AMH level to drop about zero point 0.1 to zero point 0.2 each year. If we see it dropping faster than that, it might be an indication that we should consider doing a cycle sooner rather than later. One other thing that came to my mind as you were speaking is that most insurances will cover all the diagnostic testing. Um, so to come in for a consult and have your blood drawn, typically that's covered by insurances. And we do accept all insurances with the exception of the Medicaid plans. So for patients with Medicaid, you can do that testing with your gynecologist if you want it to be covered. But typically most insurances will at least cover coming in for the consult and the blood work and the ultrasound. So the data shows that the answer is yes for eggs that have been frozen at age 38 or earlier. So we've looked at what we call the efficiency of an egg, and typically frozen eggs will have the same efficiency as fresh eggs as long as they're on the younger side. So that's a challenge. The egg itself is only made up of one cell. So you can't tell by looking at the egg if it's a normal egg or not. We do know in women under 35, the eggs that make it to the day 5 stage or the blastocyst stage when we thaw them, a little over half of those embryos are going to be chromosomally normal. So, if your egg count is good and you're young, we presume that the quality of the eggs is also going to be fairly good. But it's a little challenging to predict what the eggs will do in the lab when they're thawed and made into embryos. And so that's why I caution that the insurance policy is not 100%, is because we don't always know what the eggs will do when we go to use them. There are some supplements that may be good for egg quality. One of them is vitamin D, and another one is called coenzyme Q10 or CoQ10. So those are two we frequently recommend. There is a book that many women use called It Starts with the Egg, I believe is the name of it. That's very extensive. Might be a little too much information, but maybe you can read the Cliff Notes on that. But it does talk about also things like diet, trying to eat less processed foods, more fresh fruits and vegetables. So sort of a Mediterranean diet is generally what we recommend for our patients. Certainly, as I mentioned, smoking cigarettes is not great for the eggs, so that's one thing to cut out if you can. Marijuana use is also we is probably does affect fertility in some extent, although perhaps not the eggs themselves the way that tobacco does or nicotine does. But that's something also to consider, particularly when you're trying to be pregnant, that you would want to decrease. In terms of exercise, we do encourage exercise just in general for one's health, but I don't believe there's any data on specific exercises that are good for the reproductive health in particular. Retinol is not safe in pregnancy, but it is safe to use leading up to pregnancy. So certainly the supplements like vitamin D, coenzyme Q10 can be helpful. It depends on a woman's stage of endometriosis. Not all patients, but in some patients having a laparoscopy to sometimes remove so laparoscopy is a surgery where you go in minimally invasive, generally through the belly button and maybe two small incisions. And if there is endometriosis there, it can be removed to decrease the inflammation that might be present from the endometriosis, and that can sometimes improve the egg quality, but that's not something we routinely recommend for all women. So if you have stage 4 endometriosis, it depends if you've had surgery or not in the past, but it also would depend on sort of where one's levels are now. So if one has already the egg reserve is low and AMH levels are low, sometimes going in and trying to remove the endometriosis or cysts from the ovaries can make the egg count even lower. So that's sort of an individualized approach where we'd want to think about the whole picture, prior surgeries, age, and current egg reserve levels. I would probably see where the numbers were at, and also check. Another important thing is making sure the ovaries are accessible for an egg retrieval. So in the image that I showed, you can see the uterus with the ultrasound probe going up and reaching the ovaries without any difficulty. If a woman has very large fibroids, they can sometimes make it impossible to actually do the egg retrieval. So in that case, that's something where we would want to see you in the office, take a look at the size of the fibroids and make sure we'd be able to get to the ovaries to access them for the egg retrieval. But we have had patients 38, 39, where they are going for a surgery. And so we do discuss the pros and cons of freezing eggs before they do that. I appreciate you all coming. I think
Mhm.
knowing is half the battle. So certainly, I hope this has given you some helpful information and hints. And and yeah, we're happy to see you if you need us here. Um, and we also do telehealth consults. So if you had some testing done with the gynecologist and wanted to just review it and not physically come into the office, we also can do telehealth consults for new patients to review your history and talk about what the chances might be for you.